And to finish up today's event, we have Dr. John Bete. Dr. Bete is a pain medicine specialist and has practiced at the Cape Cod Hospital Pain Center in Hyannis since 2012. He graduated from the University of New England College of Osteopathic Medicine in Bedford, Maine, and completed his residency in physical medicine and rehabilitation at Ingham Regional Medical Center and Sparrow Hospital in Lansing, Michigan. Dr. Bete is also completed a fellowship in interventional spinal techniques, pain management at Michigan State University. He is certified by the American Board of Physical Medicine and Rehabilitation, and today he will be talking on treating patients with chronic pain. Thank you.
Thanks. I have the clicker. Where's the clicker? Oh, is it right there?
Oh, yeah. We have.
Okay. Thank you. Can everyone hear me? No? Yes? Okay, good, great. Hi. So, thank you all. I'm going to get started. There's going to be a little bit of redundancy between what all of the other speakers have said and what I'm going to say. So, I think that's a good thing. Repetition is the mother of retention, so hopefully we'll remember to take home some key points. Let's see. So I'm going to get started. I'm going to talk about pain and a very simplified pain anatomy, and then we'll kind of go into chronic pain as a disease state, and then a little bit about treatment and goals for treatment with chronic pain. I'm going to be fairly general because you can get into the very specifics and you end up taking a lot of different directions. So we'll start general, and if there's specific questions, we can talk about them in the question and answer period. So as you heard earlier today, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So you don't actually have to damage tissue to feel pain, but that's really what the pain is. Usually people describe the pain in terms of damage. And ultimately, pain is a perception. I'm going to repeat that a couple of times because I think that's probably key in my presentation. Pain's function is the body's alarm system, so it tells you when there's damage, how bad it is, what type of damage it might be. And it's going to modify your mood and your behavior. So it's got that function. So here's some neuroanatomy, and it's too complicated. We're going to use my two lollipop system. Here's the nervous system. Basically, you've got a peripheral nerve coming off of the side and going up and down, a spinal cord, and brain. So that's the central nervous system, and the peripheral nervous system is usually everything outside of that that's nerve-related. So acute pain is normal pain. It's a predicted physiologic response to noxious stimulus, and it's generally time-limited. So most of the time you go through life, you have some pain, something happened, you hurt yourself, you get better. So the pain is associated with that injury, and it's mediated by inflammation. And inflammation is a kind of a chemical process. A lot of patients will say inflammation, that's swelling and edema. And the edema and swelling is part of that inflammation, but really it's that chemical process. And that results in some acute pain. And acute pain is a symptom of disease, it's not a disease. That's going to be an important differentiation to make. So here's my little diagram. You've got some cell damage of some type. It might be a broken bone, it might be a torn ligament. A bunch of chemicals are released. The first one's usually arachidonic acid. You don't have to know that, but it starts a cascade of a bunch of other chemicals, and it's almost like alphabet soup. All these chemicals, and they're going to keep going. Their job is to alert you, but it's also to clear away any debris from broken cells and also make the area less prone to infection. So it's going to be a noxious place for bacteria to be. So there's that little cell damage. The nerves pick up on some of those chemicals of inflammation. They transduce the signal to a nerve signal. It goes into the spinal cord. The spinal cord's activated. It sends some signals up to the brain. Brain gets the signal. You say, ouch, I hurt. So if you get that paper cut, that's that initial moment of ouch. Kind of, you get some thoughts, some emotions, some sensation. But then something else happens. This is the interesting part. Your brain processes that information. You look down at your finger and say, oh, okay, a paper cut, as opposed to, oh, my finger's lopped off and I'm bleeding and I have a more pressing problem. So it processes that information, and it can decide subconsciously how important that pain signal is. And we have a thing called the descending pathway. Here it is. And so now that descending pathway is going to modulate the pain sensation going up. So now we can say, okay, how big of a problem is this? Am I bleeding to death, or do I have a paper cut? Pretty good. Eventually, you get healing. And the only thing that's left is the memory. The pain signal goes away. And this is acute pain. So as this function, it reminds the patient to avoid aggravating activity. It's going to help you prevent further injury and facilitate healing. Delayed treatment of acute pain, unfortunately, can lead to chronic pain. And so some of the things that will trigger the nerves to give you pain: heat, cold, acidity, pressure, chemical irritation by these inflammatory mediators. So here's the kind of the big picture. And perception of nociception is another way of defining pain. So we've fired up these nerve cells, they've sent an appropriate signal up to the brain gets them, and that perception is pain. And again, your brain is going to parse out that information to all sorts of different areas. It's going to compare that information to memories, and all the other things that fill your head, all the different thought processes. So it's a perception. Now, it's not the only perception. At every given moment, the brain is processing a lot of information. And so you have many perceptions ongoing simultaneously. One of them might be, I'm hurting. Listed a couple other things there. You know, I've got wants and needs. I've got a schedule to keep. The weather's bad. I have religious obligations, if you are that way, or spiritual obligations. And so when we get to treating pain, we're going to treat every step along this path. And so modulating that perception can be done by addressing lots of different things. Talk about genetics. We can't modulate that, but understanding someone's genetics might predispose them to certain disease processes that are going to cause inflammation and breakdown of different body parts. Learned behavior, cultural and worldview, mood, stress, anxiety level, sleep and wake efficacy. Do you have good sleep habits that allows your body to restore itself and take care of itself? Pain memory. Oh, it's my back pain. It happens every time the weather's bad. You know, or maybe this is not like the pain I've had every time the weather gets bad. This is something new and alarming, and maybe I got to get to the doctor to find out what's going on. Self-efficacy. This is an important thing, I think. Self-efficacy is your ability, your belief that you can achieve what you want to do. So people that have high self-efficacy tend to have a little bit less likelihood that they're going to have chronic pain. People with low self-efficacy, they don't feel that they can achieve their goals, have a harder time dealing with pain. And that's maybe an important tool when you're dealing with chronic pain. Your activity level and your inactivity. So the person, like we've talked about, exercise is really important. Daily exercise is really important. We'll go over that a little bit. And inactivity is detrimental. Your personal experiences, your expectations about pain, lifestyle, diet, tobacco use. Tobacco use is associated with worsening chronic pain. Diet, we're learning a lot more about pro and anti-inflammatory diets. So if there's something that aggravates your system, like you have a nut allergy, you want to avoid nuts. And sometimes those allergies are the allergies you think about where you get prophylaxis, you can't breathe, your airway restricts down, but other times it's much more mild, where you eat the thing that you have some sensitivity to, like gluten or nuts, lactose. You don't have that horrible life-threatening condition of anaphylaxis, but you might just feel lousy. And you might not even know it, because it might be something that's been in your diet the whole time, your whole life. And once you take it away, you feel a little bit better. You turn down the amount of inflammation that's happening systemically. Let's see, exposure to medications, some good and bad with that. Level of preoccupation. So if you've got a lot in your life to be concerned with, when are you going to go golfing? friends and family, work, school, hobbies, spiritual stuff. There's less room. Your brain is putting more focus on those things than on that pain signal. The person that doesn't have those things, they're underemployed, they're depressed, they're socially isolated, they're going to have a harder time dealing with pain. And I talked about religion and spirituality. So those things are all very important. And so we talked about mind, body, and spirit. And so some of these things I've talked about are kind of mind-related. And all of them will drive your behavior. So addressing someone's behavior and their mind and spirit, as well as all the other medical things that doctors can help you with, is going to be just as important. So chronic pain. This is different than the acute pain we talked about. Chronic pain doesn't go away. It's any pain that lasts greater than 3 months or longer than expected after normal tissue is healing. It can be due to a chronic medical condition, chronic inflammatory state, changes in the nervous system, and there's multiple theories about why this happens. I'm not going to go into all those theories because they're theories, and I think it's less important than some of the other take-home. Okay, chronic pain. Now, chronic pain is a disease of the nervous system. It's no longer a symptom. It is the disease. It's in response to prolonged tissue damage and inflammation. And essentially, the nervous system is your messenger system to the outside world. And something's gone wrong. It's broken. Approximately 100 million adults in the U.S. have chronic pain. Estimated cost of $600 billion. That's a lot of money. And this is old information, so I'm sure the numbers are higher now. This is like 2013 or 14, I think. A survey of 1,000 adults showed 57 had experienced chronic pain. 33% reported that pain is disabling, so it's preventing them from lead the active lives that they'd like to be able to do and might be able to do. So here's chronic pain. Here's my little picture again. We've got some ongoing tissue damage or inflammation. Maybe it's a herniated disc, maybe it's a tendonitis, a bursitis, whatever it is. You've got this pain signal that's coming in, it's going up. You've got the descending signal, brain's thinking about it, just like we described. What happens is when the healing occurs, that peripheral nerve is no longer activated, but for some reason, the central nervous system stays activated. And probably the most important place in sort of research is at the level of the spinal cord. They talk about the dorsal horn of the spinal cord. Again, you don't have to know that, but it's basically where the peripheral nervous system meets the central nervous system. And this is an important little diagram. You don't need to know all the details, but each of those little colored bits are proteins that are responsible for transmitting a pain signal. And our drugs, the drugs that we use, can affect these proteins. So when we use drugs to treat pain, this is one of the ways that they work. They work in the central nervous system. Another way is to turn down the inflammation. So non-steroidal anti-inflammatory drugs do that. Steroids do that. But most of our other drugs that treat pain work here. Interestingly enough, if you have really great eyesight, you can see that one of them is a CB molecule. That's where the cannabinoids work, which we think is why marijuana seems to be of some benefit. But it's just one of many. The take-home picture, the spinal cord is where a lot of this chronic pain is happening, we believe, and there's lots of different ways to address it. So chronic pain, the nervous system isn't fundamentally changed, and in rat models you can see the changes in the nervous system. So we know that it's real. So when you meet these people that are painful and cranky and depressed and miserable, try to be understanding. Their nervous system has fundamentally changed in a pretty horrible way. At that point, you're unlikely to have complete resolution of pain, despite all of our treatments. The goals of treating someone with chronic pain are different. I'm no longer trying to get the pain away. I'm just trying to manage it. But it's still just a perception, even though it's chronic. So if someone's got pain that's bad, a lot of different people are helping them with that. Things you might think about are blood work, a test called an EMG, radiographic tests like x-rays, MRIs, and CT scans, and if need be, a pain consult and interventional procedures to help diagnose as well as treat the pain. So a lot of times I'm doing procedures on patients, injections in their neck and back. I don't know if they're gonna work. I've got an idea that they're gonna work, and the fact that they work is of diagnostic value. So if I can numb up a thing that I think is causing pain and the patient comes back and says, hey, I felt great for a while, I know where the pain's coming from, as opposed to before, I just had ideas. Now, there's lots of disease states that other doctors could help a painful patient with. The rheumatologist, the neurologist, the orthopedic surgeons, general surgeons, infectious disease, neurosurgeons, hem-onc. Cancer oftentimes causes severe pain. And so if you think that the person needs to be tied in, part of my job is making sure they get to the right doctor, because I'm treating the pain, not the other stuff. And when I'm treating pain, goals to minimize the pain and suffering. So if I can get that pain from a 8 to 9 out of 10 down to a 5 to 6 out of 10, most of my patients are pretty happy. There's some that come in with an expectation, especially the younger patients, because every other time they had pain, they got better. And now they've reached a point in their life where they've got a disease state that they might not get better. And my 70, 80-year-old patients have no problem understanding that. They've watched their friends, their family, their peers kind of go through this process where the later half of our life, we have some degenerative processes ongoing. Young people have never experienced this. Like, what's going on? Why am I not getting better? So it's alarming. One of the things we want to do is help them develop healthy coping techniques. Help contextualize what's going on here. Is this something that I need a surgery for or not? Sometimes it is, sometimes it isn't. So developing therapeutic behaviors and habits is important. Chronic pain is generally managed and not cured. So treating chronic pain, you want to develop reasonable expectations of the disease processes that are ongoing in that individual, and you want to develop reasonable expectations for treatment modalities. I've got some injections, they're great. They can help people with certain problems, but almost none of my injections fix the pain. The pain's gonna come back once they wear off. 3 to 6 months. So you have to ask yourself, is 3 to 6 months of less pain worth doing? And then you might have to repeat the process. So they come back and we do it over and over. They get a little frustrated. I don't like having injections every 6 months. Well, you don't have to. But if they're helpful and they bring quality of life, I'd say that there's a good argument to consider them. So treating chronic pain, you want to treat the underlying etiologies when possible. You address psychology and psychiatric issues for sure. You want to prevent disability. You want to encourage adaptive and maladaptive behavior. And unfortunately, this is trial and error. So when you come in and I say, oh, I think I know what's causing your pain, I don't necessarily know what's going to work best for you. Treating of chronic pain. We talked about there's multimodal or polymodal approaches. It means the same thing. You're trying different ways to treat the pain. It's not an opioid program. Some people come, they say, I just want a pill. That's what my other doctors gave me. Why don't you just give me a pill? They work. However, when they're used chronically, opioids don't work that well. If you use them chronically, they only relieve about 20 to 30% of the pain. They work great acutely. That's why we use them when you have a trauma or you have a surgery, you need some pain relief while you're recovering from that. But if you've got chronic pain that's not going to go away, then you're going to have to take these, whatever medicines you take, chronically. And opioids are problematic. So we talked about the polymodal approach to chronic pain. Modalities. When I say modalities, a physiatrist, well, that's my kind of doctor, physical med and rehab, what we're referring to is using ice and heat, cryotherapy, Mother Nature's pain reliever. Heat, moist heat can also be helpful. I think those are underutilized in some populations. Well, as other people come in, it's like the first thing they did, they iced it. Great. And again, it being whatever is causing their pain. Physical therapy and exercise. We've talked about that a little bit. Injections and interventional procedures. That's what I do. One of the things I do. Psychologic approaches and coping techniques. Sometimes I send people to a neuropsychologist so that they can learn effective coping techniques to deal with chronic pain. Psychiatric comorbidities. So people don't My patients don't live in a vacuum. They have other ongoing issues that can make it harder to do some of these things. And if their bipolar disorder is not well controlled, or their depression is not well controlled, it can interfere with my treatment. So I want to make sure they're plugged in with appropriate care. Complementary and alternative medicine, very important, oftentimes underutilized. With that, diet, I talked a little bit about pro-inflammatory versus anti-inflammatory diets, and rational polypharmacy. So if I am going to use drugs, I want to try to use drugs in a smart way. Cryotherapy, ice bags, the frozen bag of peas, which a lot of people know about. You want to avoid that in insensate areas so you can actually cause problems if you over-ice things. You can get freezer burn. You can cause numbness. If the frozen packs are uncomfortable, you can put them in a refrigerator rather than a freezer. A lot of my patients can't tolerate a bag of ice, but they can tolerate a gel bag that's been in the refrigerator for a while. Moist heat, every 15 to 20 minutes, every other hour. These are a couple of things that I think are very underutilized and you can do at home. Physical therapy. When I send someone to physical therapy, oftentimes what I'm sending more is to help them develop a home exercise program that they can tolerate. So the idea is they're going to start exercising pretty much every day. It's got to be performed every day, or at least a minimum of 3 times for a week for it to be effective. And initially, it's going to make their pain worse. And so I like to try to warn them about that, because here you go to the pain doctor, he sends you to the physical therapist, and the physical therapist hurts me. It doesn't make a lot of sense unless they understand. It's kind of like you're in training, like a runner. Runner is going to train for the marathon for a little while. It's going to hurt. Eventually, it's going to start to feel better. And it can take weeks to months before the benefit of that exercise program is achieved. It's another reason why I can't just give you some exercises here, go do them, because it's might not be the right set of exercises. I need the therapist to kind of keep an eye on you and figure out where you're at. So they start at the appropriate level, advance the exercises so you can tolerate them. If you're doing things incorrectly, make sure you're doing them correctly. But physical therapy and home exercise, or exercise, is, I think, critical for people with chronic pain. And you want to encourage dialogue between the patient and the therapist so they know that just because the therapist told them to do something, it might not be the right thing. The therapists do the best they can. If they've asked you to do something that's causing some mild aches and pains, that's probably normal, but you should still discuss it with them, and so they can modify their behavior to better suit you. So therapeutic exercise and home exercise program. One of the things that this benefit does is this idea of tensegrity. I'm going to take it's kind of a side note here. So the musculoskeletal system, it's got rigid parts, strong, straight parts like our bones, and soft parts like the muscles, tendons, and tissues. And when everything's got a little bit of tone in it, and your posture is good, and your lifting techniques are good, you minimize the amount of damage and inflammation to the body. So you want to maintain it in that condition, so that way it can meet the daily stresses of life. And so this idea of tensegrity, where there's enough tension in the soft parts to keep the rigid parts in the right position, I think is critical. And when that happens, our bodies are pretty amazing. They're designed to offload the joints, and the joints are usually the first thing to go for most people. The first thing where they're getting a lot of inflammation. It's usually where the chronic pain is happening. And the way I see the world, the discs are just a modified joint. And so if we can offload the discs and offload the joints as much as we can by daily exercise, you're going to lower the amount of inflammation in those joints. Inflammation in joints is, by definition, arthritis. So this exercise program is going to help do that. And here's a little model of these little tensegrity models. And they're just a theoretic model to give us a sense of what's going on. And on the left, there's a picture of some sticks. They don't touch each other. They're held near each other by tension in the strings. And if the tension in the strings is equal and appropriate, those bones, those rigid structures never touch each other. When people get into trouble is when our bones that are involved in joints rub against each other. We all know about bone-on-bone arthritis, or knee pain patients who've got knee arthritis. At one point, the cartilage in the joint protects the bones from touching each other. Another point, the joint's worn out, degenerated, and the bones are rubbing, and they're crushing living cells. Those living cells are releasing arachidonic acid. This is the first step in the inflammatory cascade. And voila, we have arthritis in the joint, inflammation in the joint. So again, the exercise is to help protect the entire structure, but especially the joints. So physical therapy has other benefits. It releases natural endorphins. So people talk about runner's high. If anyone likes to run or did run, they exercise for a certain amount of time, and then they get this euphoric feeling. Your body's releasing endorphins, which are chemically similar to morphine. Or I should say morphine is actually chemically similar to the endorphins. And it doesn't have to be running to get the runner's high. It can be any exercise that's done for a prolonged period of time. So that's a benefit. You're also getting improved respiratory function, cardiovascular function, improved sleep quality, all of which are going to affect the amount of inflammation that's ongoing. So again, the physical exercise is critical. It also changes your focus. I got to get to the gym. I got to do my exercises. I've got to go to the pool. I got to swim. You know, you're focused on getting better, not on poor me, I'm suffering. It also really results in decreased stress. And if you're stretching out before and after your exercises, you get muscle relaxation. Yoga is a great way to do this. And a lot of patients say, I can't do yoga, I can't bend like that. That's crazy talk. But the reality is, there's a couple things called gentle yoga and chair yoga that are available in our community at various yoga studios. And these are designed for people that are very painful and have limited range of motion. So when patients say, I can't do yoga, I'm saying, oh, yes, you can. Just go try. Unfortunately, yoga is not a covered benefit. So it's going to be out-of-pocket expense. And I really don't want patients using videotapes that they checked out at the library or DVDs, because you really want someone who knows what they're doing, kind of keeping an eye on things, and a good yoga instructor usually does. Other options, someone else mentioned Tai Chi and Pilates. Pilates are kind of aggressive, so a lot of people can't tolerate them, but Tai Chi is very gentle, and so most of my patients would tolerate those. We talked about injections done initially for diagnostic purposes, but later they're done for therapeutic purposes. So I've got some patients who, I see them once or twice a year, they get their shots, they go back and they say, I can play golf and I can interact with my family and take care of my home. For some people, it becomes a matter of living independently and not going to a nursing home. Some it's a matter of going to their job, be able to function. But unfortunately, most of these only last 3 to 6 months. Sometimes they last longer, but in general, they're fairly limited. Sometimes I'm doing so the person can get to the physical therapist and do more exercise. So psychological treatments of chronic pain, this includes relaxation techniques, addressing pain beliefs, developing adaptive and maladaptive pain behaviors. Might include a thing called biofeedback, where you get to learn where your body is going to start to be painful and how to change your activity, your behavior in response to that. Also talk about addressing anxiety and depression that occurs with chronic pain. I don't do this, but I would send someone for either psychological counseling or neuropsychology. Psychiatric comorbidities, we talked about that. Want to make sure if they do have clinical anxiety, depression, PTSD, bipolar disorder, or substance abuse history, they get treatment for that. And also that's going to play into which medicines I may or may not want to use with that person. Complementary and alternative medicine. This is kind of the standard list. There might be a few other things that I haven't put up there. And each of these things we have responders and non-responders. So people say, well, what about chiropractic? I say, that's great. Might work. Might be very helpful. It might be a thing that saves you so you don't have to get my injections, which is awesome. Acupuncture and osteopathic manual medicine. Some similarities between that and chiropractor. Those fall into the category of complementary medicine because these people all have some medical training. The alternative treatments, these people have less medical training from a Western standpoint. Therapeutic massage, meditation, Reiki, naturopathy, homeopathy. So rational polypharmacy. Okay, it's bad. We've tried a bunch of stuff, modalities, heat and cold. Maybe we've done injections, maybe we haven't. Or maybe the first thing that happened is you went to your primary care doctor and he gave you some medicine. And he was hoping to not have to give it to you for a long time, but the pain's not going away because, as we've said, you've got chronic pain syndrome. Now we're going to choose what medicines we're going to use, what we're going to try. And again, this is a little bit of a trial and error process. You want to focus the medicines to the disease processes. So if you think this is a neuropathic problem, meaning the nerves are damaged, you want to use certain agents like gabapentin, Lyrica, amitriptyline. If you think it's an inflammatory problem like an arthritis, you're going to stick with the non-steroidal anti-inflammatory drugs and maybe some steroids. And if you need to, you want to use multiple agents that are going to target different parts of this pathway. And with chronic pain, there's usually an element of inflammation and an element of nerve pain. So using both of those types of medicines are going to be helpful. You want to use the lowest effective dose to achieve functional goals, not pain eradication. So sometimes my patient's a little frustrated. How come you won't give me more? I still hurt. Well, you just told me the medicine's giving you 30% relief of your pain. That's all I'm expecting it to do. Because I'm not expecting to get the person pain-free. And if they're expecting me to get them pain-free, we're going to have some issues. We're going to butt heads. And the idea is I want to decrease the risk with the use of the medicines. And so here's a list of the types of medicines that I commonly prescribe. Non-steroidal anti-inflammatory meds, those are ibuprofen and naproxen over the counter. There's prescription strength versions, but they've got problems. They can cause renal disease, GI upset, bleeding ulcers. They have a cardiac risk. Tylenol causes liver toxicity. Anti-epileptics, these are gabapentin and Lyrica. They can be sedating. They can be, in some patients, a fall risk. In some people, they cause edema. Tricyclic antidepressants, amitriptyline, nortriptyline, they're great, but they can cause serotonin syndrome. They can also be sedating. The newer antidepressants, SNRI, NRI, Cymbalta, Effexor, these are great. They work with that descending system that we talked about earlier. But they can also cause this thing called serotonin syndrome. They're activating. Some people don't tolerate them. They can't sleep well on them. Muscle relaxers, there's a variety of them. Flexeril and Robaxin, probably the most common. They're sedating. They can also cause serotonin syndrome. Antispasticity medicines, they work in a couple of different ways. Baclofen and tizanidine are probably the most common. Baclofen, if you stop it abruptly, you can have a seizure, that's no good. Tizanidine has liver toxicity. So again, any one of these agents, you have to be careful. Last on my list, because I don't want to start with them, I want to save it for when I really need it, is opioids. There's the risk with opioids we all know about, dependence, which is a normal response to the use of an opioid. If you stop it, you'll feel lousy. There's misuse and addiction, also called opioid use disorder. That's the one we hear about in the news, the bad people that are misusing their drugs. They have a disease, and I encourage you all to think of people struggling with addiction as unfortunate people that have a disease process that should be treated. The other things that are kind of mostly people are familiar with the opioids, they cause constipation. The dangerous one is respiratory depression. Constipation is also dangerous. It can cause a perf bowel, and that's no good. A perforated bowel can lead you to the emergency room, and you might not survive it. Respiratory depression, that's what kills the people that overdose. They stop breathing. The effect of use of opioids and respiratory depression is perhaps doubled when alcohol's involved, so you want to make sure you're not using alcohol with the opioids. The one that people are less familiar with is called opioid-induced hyperalgesia. This is a funny thing. If you're on high doses of opioids for a long time, they do just the opposite. You're taking them to reduce your pain, but they drive the pain signal. It's a very bizarre thing. And 5 years ago, when people in this community were being prescribed high doses of opiates for their chronic pain, that's really changed quite a bit. I had a lot of people who would come in, they've got opioid-induced hyperalgesia. Now their mindset is, this opioid takes away my pain. And in reality, this is the thing that's driving their pain. So my solution to them is to take away the opioid. They look at me like I'm crazy. But then, if they're not struggling with addiction, then they're going to want that drug no matter what. Some of them come back and say, I went off the meds and I feel a lot better. Not just the constipation, not just the kind of, feeling kind of drugged, but they actually have less pain. It's pretty well documented. So we talked about functional goals. So what is that? So when a patient comes to me, they're going to have chronic pain. We've discussed, I'm going to do all these different things, injections and medicines and exercise, physical therapy, heat and cold modalities, doing the best we can, but what are our goals? And we kind of want to start to address these fairly early on in our relationship. You know, getting them so that they can go to physical therapy, do their home exercise, making sure they can go shopping, walking, gardening, social outings, weight loss, traveling by car or bus. It's hard for people with chronic pain to go visit their family member if they can't sit in the car or the bus for any length of time, or the plane. Make sure they have hobbies, make sure they're participating in sports, and daily exercise. Those are functional goals. So affecting nociception or treating pain, there's some things to consider. We talked about make sure you know the underlying cause and the pain is appropriately treated. They're connected with the right physicians, doctors, surgeons, chiropractors. Polymodal treatment of pain, we're going to use complementary and alternative forms of medicine. Interventional treatments, that's where I come in. Psychologic treatment, psychiatric issues, exercise and activity, sleep and wake hygiene, that's a whole other talk. Diet and spirituality and religion are all important. Remembering that pain, whether it's acute or chronic, is just a perception. Thank you.